To put things in perspective, less than 3% of inpatient bills in private hospitals today exceed this $60,000. So the vast majority of inpatient bills do not actually hit the $3,000 copayment cap. This copayment cap could not be applied to all claims, as it would negate the effect of copayment once the $3,000 cap was reached. Let me explain. Take, for example, if the copayment applies to all claims, policyholders may choose a treatment which costs $100,000 instead of another equally effective treatment at $70,000. This is because the policyholder would pay the same amount of $3,000 for either option once they breach the $60,000 limit where the $3,000 payment cap has been reached. The additional costs would then be borne by the insurer, and this eventually translates to higher premiums for other policyholders. Therefore, the cap was applied to paneled doctors, where there are established fee arrangements to ensure that appropriate and cost-effective treatment is provided. We want to emphasize that patients can make claims for all treatments covered under the IP, regardless of whether the specialist is on the panel or not. Nevertheless, some doctors have expressed concerns that IP panels do not have an adequate number of specialists, restricting referrals to the appropriate specialists who may not be on the panel, and therefore limiting the continuity of care. Patients have also raised concerns that the doctor they are comfortable with or are familiar with is not on the panel of their IP insurer, and they may not enjoy the additional benefits such as the $3,000 copayment cap. To address this, MOH has encouraged all insurers to grow the size of their panels, and some have already increased the number of specialists on their panels by more than 40% since August 2019. Today, more than 70% of private specialists are on at least one IP panel. Some have asked insurance panels to be expanded to include all doctors, so long as they do not have a poor track record with the Singapore Medical Council or SMC. However, some doctors may choose not to be empaneled, as they may already have a sufficient pool of patients, so the doctors do have a choice to not be on panels. This is especially the case for areas where there are very few specialists locally. Hence, MOH encourages IP insurers to enhance their pre-authorization processes, to give approval for hospitalization or treatments and their associated costs beforehand. With pre-authorization, insurers are able to assess treatments for medical necessity and fee arrangements and appropriateness, including for doctors who are not on their panel. And patients can also have the greater peace of mind, knowing that at least a significant portion of their bill will be covered by their IP. With pre-authorization, the risk of runaway bill sizes would then be minimized. Hence, some insurers have extended the co-payment cap to pre-authorized claims for treatment by non-panel doctors to provide policyholders with greater assurance, and we certainly encourage more to do so. While policyholder benefits may differ depending on whether they see a panel doctor or a non-panel doctor who is pre-authorized, these benefits should not differ to the extent of prohibiting patients from seeing non-panel doctors or influence patient choices in an undesirable way. MOH recognizes that some policyholders may wish to switch insurers, whether for more competitive premiums or for better benefits such as access to more panel doctors, but are unable to do so because of pre-existing conditions. Some have asked if insurers can simply use MOH's fee benchmarks to determine all insurance payouts. As fee benchmarks are designed to be reasonable ranges of fees for the large majority of cases, insurers can generally take reference from the benchmarks for most payouts. Doctors do charge below and above the benchmarks depending on the nature and the complexity of the cases. However, insurers also need to take into account the medical complexity and specific clinical circumstances and deviate from the benchmarks for justifiable and exceptional cases. According to LIA, between 5% to 15% of IP claims for certain fees were approved above the upper bound of the fee benchmarks, depending on the insurer. Claim scrutiny by insurers may have been perceived as challenging a doctor's professional judgment. Insurers scrutinize claims to ascertain whether treatments were medically necessary and charged appropriately. This actually protects the interests of policyholders who may otherwise see their insurance premiums rise should claims be paid out indiscriminately. MOH recognizes that this is an important process for the integrity of the healthcare system, and it is a common practice internationally. It is nonetheless important that the process be handled professionally and efficiently by each insurer. Insurers should not make the process onerous and ask for unnecessary information unrelated to the claims, imposing a heavy administrative burden on the doctors. The questions and information sought for common conditions can be standardized and streamlined, so it will not be perceived as questioning the decisions and judgment of the doctors.
The recent public exchange between the Singapore Medical Association and the Life Insurance Association of Singapore has put into focus the role of the regulator, namely MOH. Even as I acknowledge SMS's establishment of the MHIC, which has been set up to look into some of these issues, I have nonetheless two supplementary questions for the SMS. Firstly, would MOH, as the regulator, be amenable to setting up a database transparent to both doctors and insurers to allow parties to compare and assess their bill sizes with a view to better manage medical inflation in the public interest? The second supplementary question is in conjunction with the first, which is, together with the establishment of the database, would MOH as regulator consider setting up an independent panel of assessors under its purview, which would be accessible to patients, doctors, and insurers to resolve disputes about fees and the necessity of medical procedures? Thank you.
These two items are actually already being done. The first one on the database for bill sizes, when we have the fee benchmark advisory committee, in fact, the database on fees that are charged across a diverse range of procedures across various institutions are already available for the committee, which comprises of practitioners and insurers to actually collectively deliberate on what the kind of benchmarking ought to be. So yes, the database is available, and I think that will provide some scrutiny by the relative stakeholders to ensure that whether it's payouts, whether it is benchmarking, considered fair to the policyholders and to the payers as well. The second issue on independent assessment, as you hear from my reply earlier, we will be setting up a claims complaints panel that comprises of the insurers plus also the Academy of Medicine of Singapore, which are specialists in the respective fields. So that provides some degree of independence from the professional side of both the stakeholders to really look at any areas in which, whether it's insurers or doctors, have got some unhappiness over the way payments are done or the way a certain case is being assessed by either party. So yes, there will be an independent panel that is really going to be in the works.